Sure. I'm going to talk about our collective challenge of reducing surgical waste. I have no financial interest actually in global warming. So first of all, why should we care about our environmental impact? Well, first of all, although we're specialists, we are physicians. And I found this surprising. A little over a year ago, the WHO, in the middle of the pandemic of the century, said that it is an infectious disease, but it's actually climate change. It's the biggest health threat facing humanity, with a large projected increase of deaths due to a number of impacts. And this is disproportionately going to affect poorer countries and poorer communities. In ophthalmology, the IAPB has sounded a call to action, again, projecting a large number of visually disabling conditions indirectly related to climate change, again, disproportionately affecting the poor. The healthcare sector is almost 5% of global greenhouse gas emissions. If healthcare was a country, it'd be the 5th largest emitter. In my country, in the US, it's nearly 10% of our greenhouse gas emissions. We're the 2nd largest contributor to landfill after the food industry. And the typical spread is about 5% across other industrialized countries. What's also alarming is how much this has increased in the last decade. And the lion's share is actually coming from ORs and labor and delivery. And about 70% is from the supply chain, the manufacture, and the disposal of this. And of course, for this audience, we don't have to explain that the burden of eye surgery volume is going to increase with aging. For this special issue on planetary health from the Royal College of Surgeons of England, we were invited to do an article we called Frugal Innovation. And the idea was that if you want to learn how to be more efficient and be more sustainable, we have to look at lower resource settings who don't have the luxury of wasting unnecessarily. In my Ridley Medal lecture a few years ago, I highlighted the Aravind eye care system in India and their ability to do 60% of their services, including surgery, for free. This is our paper that won an award in 2019 when we were able to show with 2 million consecutive surgeries the impact and benefit of using intracameral moxifloxacin. But there was a second very important message here. In order to provide all of that free surgery, all of the 11 Aravind hospitals routinely reuse gowns, gloves, tubing, phacopacs, bottles, sutures, intraocular and topical drops. And you can see here multiple patients in the operating room, they're not wearing gowns. Now, if any of these were done in the United States, our center would be closed down because each of these is a violation deemed to be so dangerous that we would not be able to operate. So then the question is, where they are doing this routinely, shouldn't this really increase their infection rate? Well, we showed in these 2 million cases that it's 4 per 10,000. So what is it in my country where we are mandated to do everything single use? Well, it turns out it's the same. This is from the AAO IRIS registry, 8.5 million cases during an overlapping period. There was no difference. And also in the US, again, about maybe half of surgeons during this time were using intracameral antibiotics. If you use intracameral moxi, Aravind's rate is 1 per 10,000, despite reusing everything that I showed you here. Now, this is the other striking difference. The carbon footprint of one phaco in the UK would be equivalent to driving an automobile 500 kilometers. At Aravind, it's 1/20th that. And where is the difference coming? In green here, that's procurement of supplies. In red, that's procurement of pharmaceuticals. So it's pretty staggering. This is my efficient OR in the US, 1 day's trash compared to Aravind. So we have no difference in the infection rate, despite the fact, and we are, because of the fact that we're throwing everything out in the United States, we have a 20-fold increase in the carbon footprint. So you reach this very disappointing conclusion that we are generating all of this surgical waste without really any benefit coming from single use. Now, I co-chair this task force in the US from the Academy and ASCRS OOS is our Outpatient Ophthalmic Surgery Society, and the Canadian Ophthalmology Society. We did the first questionnaire and survey of attitudes towards OR waste. We also did this in Europe, and that will be published in the April JCRS. In both surveys, overwhelmingly, people were concerned about global warming, felt trash was excessive, wanted more reusable options. If they were the same cost, 10 times as many of us would prefer a reusable versus a disposable instrument. And then in terms of manufacturing industry, strong consensus that they need to spend more time looking at reducing packaging and considering the impact of their products on the environment. Everyone wants the manufacturers to give us more reusable options and also more discretion in the so-called IFU, instruction for use, to be able to reuse things. We went through a bunch of products, topical, intraocular drugs, supply items, and asked, are you reusing them? Are you willing to reuse them? So you can look at something like multi-dose bottles for topical. Everyone feels it's safe to reuse those in multiple patients. But just as many feel that's the case on these single-use items like intraocular antibiotics and miotics. This is willingness to reuse phaco tips, IA tubing, willingness to get rid of the full-body drape, not changing the patient into a gown. Actually, 2/3 are willing to use the same surgical gown without changing it in between consecutive patients. So if on these two surveys we have such a consensus, you have to ask the question, well, why are we wasting so much? Well, first of all, you have to look at these guidelines. And as you look deep, these are really not based on studies in most cases. These are expert opinions from groups such as nursing organizations that create these guidelines. And so they are eminence-based, but not evidence-based. So to give you an example, this Association of Instrument Manufacturers gets these infection control nurses together for these little meetings. And this is the results. Now this is a poll, and it's perceived risk. Reusable surgical devices, reprocessing devices that weren't clean, not following the IFUs. This is perceived risk. So they come up with guidelines that, we have to be aware of inadequate cleaning and not following the instructions for use. And the problem with eminence is there is bias. And I would submit that if you get a bunch of infection control nurses together, there is going to be a bias there. One such recommendation from our OR Nursing Society said that, it would be safer if we covered all the hair and covered the arms of everybody by wearing these jackets. And when this was studied at Alabama, there was no difference in infection, just a huge amount of money to comply with that. So here's an example where the perception that it would be better was contradicted by the actual evidence. Another problem is that by default, regulations for all of general surgery get applied to us in ophthalmology. So in the United States, we faced having the inability to do short cycle steam sterilization till this task force that I chaired. We did some studies on this. We eventually had to publish our own guidelines for sterilization of ophthalmic instruments so that we weren't by default having to apply to everything else going to general surgery. And so this is this task force. Now, the manufacturers for every product have to package an instruction for use. And why do they always say single use? There's a number of factors. One is liability. One, it's easier to get FDA approval. You have to validate that it's safe when you reuse it. And obviously, profit is greater with single use. This is the instruction for use that's packaged with a monofocal lens, every one of them. This is with the injector tip. We not only never read them, but this is with every single one of them. So we took an example, single-use phaco tips, and we analyzed this at Moran, and this was our study that was published, and we could not find any difference between a new tip and one that had been reused multiple times. Finally, liability affects lots of decision-making in the operating room. And this is where, although surveys are not scientific, when we can show how much our colleagues, are reusing things. I think this helps. Remember that this section here is pharmaceuticals and how big that applies. The reason pharmaceuticals are that way is because of the carbon footprint of the manufacture of them. And here's just one study that looked at eye facilities and found that not only was there enormous amount of drug waste producing this type of cost per year, but the carbon footprint of that drug waste was also extremely high. You go back to the survey, it said everybody agrees we should be able to use multi-dose bottles on multiple patients. Less than half were currently doing this. We did a sub-analysis and we found that if you worked in a surgery center where you were reusing them, if you were in a hospital, you were throwing the bottle out after just putting it in one patient. And so we worked on this for some time. We got these 4 U.S. societies to endorse a set of recommendations after we did sort of a literature search, reviewed the policies of the regulatory societies, and published this last September with the conclusion that you not only can use multi-dose bottles in multiple patients, you don't have to throw them out until the date of expiration. And this is in our position paper. The reason we can't operate on multiple patients and why we have to change gowns and put patients in gowns is this whole idea of cross-contamination. Well, what happened with COVID, here's one study, 2, 3, 4, 5 studies that basically showed that when we do phaco, we do not aerosolize virus, we don't aerosolize germs, so the risk of cross-contamination in the air in the room is literally remote. And then Aravind did a study as well, and this is, we published this in the BJO. What happened is they had to stop surgery like everyone else, and when they reopened in 2020, they changed some things. They had patients wear gowns. They only had one patient in the OR at a time, and they changed their gloves and gowns between cases. This is the whole cross-contamination idea. Well, what did it do to their bacterial infection rate? It didn't change it. So imagine we're over here on the right, and if we were to do these things like, not changing gowns and gloves, you can see that there's no evidence that there's a danger in doing that. Finally, many of the respondents wanted medical societies to get involved in sustainability. So we founded and opened up iSustain. You can see the 3 societies that co-sponsor this. It's the first website dedicated to sustainability and ophthalmology. This was inaugurated at our ASCRS meeting on Earth Day a year ago. Here is my team that helped in putting this together. And I'm just delighted that both ESCRS and the Academy have now joined ASCRS as the 3 co-sponsoring societies moving forward. We now are up to more than 20 member societies that join iSustain, including the Hellenic Society, which was one of the early ones to sign on. The mission, well, it's really about education and networking, but we need to collaborate with industry, and we certainly need to look at research and innovative ideas for reducing waste. These are the different parts of the website. This is the part for the operating room where you can calculate your carbon footprint. And I mentioned all of these task force papers and documents, and we have put them all together here so that all of ophthalmology can get on board behind this. And we need to set up our own standards, otherwise we are by default following everything for general surgery. Every section has resources because we need to have evidence when we do this. Here is the section that has all the parts about the surgical drug waste, which is costly and, again, environmentally impactful. There's a lot that industry is actually doing, and they're very interested in working with us. We've now had 3 different, and at the ASCRS meeting we'll have our 4th half-day workshop with them. We have a lot of projects going on, and I'm very pleased with their efforts to be better. Now, what can you do now? Well, we can start not throwing out a bottle after a single use or after 1 month. You can use it till the date of expiration. Update the surgical packs, eliminate the things that you're not using. Get rid of the body and head drape, eliminate a patient gown. look into reusable things that you can reuse right now. Alcohol, hand sanitizing is another, and I think educating the staff is probably the single biggest thing, because they know what is being used and what's not. And if they understand this the way we do and the way you now do, they'll be a part of the solution. This was at Bascom Palmer. This is the water and the money saved on an annual basis per OR by using alcohol scrub versus a sink every time. And this is what we do and have done for many years. We cover the patient with a blanket. There's a non-sterile blue drape under their head to catch the water, and just one plastic drape on top. So as I said in this editorial, we have the highest surgical volumes in all of medicine. And so we actually have this compelling opportunity, but also an obligation to lead efforts in medicine, but certainly in our own profession, to reduce the impact of unnecessary waste. Thank you very much.